Good afternoon, everybody. We'd like to welcome you to today's session. It's Lessons Learned from the Past, Addressing COVID-19 Disparities for a More Equitable Future. I'll start off briefly with a couple of housekeeping things. So the first is that we have all of our participants muted. You won't be able to speak during the session. However, we would like you to ask your questions using the Q&A box, and to please use the Q&A box instead of the chat box. So with that, I'll go ahead and get started. My name is Michelle Agunwale, and I am a General Internal Medicine Research Fellow here at Johns Hopkins University School of Medicine, and my research focuses on racial disparities in maternal health outcomes. And I'll turn it to my co-moderator.
Thanks so much, Michelle. My name is Utibe Essien. I'm an assistant professor of medicine at the University of Pittsburgh. Similarly, research focuses on health disparities in cardiovascular disease. And we're really thrilled to have an incredible panel to speak with us today. And before we introduce them, I'll let Michelle introduce kind of the plan for the session.
Yeah, absolutely. So I think that many people who are listening here are aware that disparities in COVID-19 have really been discussed pretty broadly. We've really seen a reflection from a range of thought leaders, from clinicians and public health practitioners to economists, historians, and policymakers. But as Dr. Essien alluded to, today we have the unique opportunity to have this discussion with a panel of nationally and internationally recognized leaders who have really spent their careers advocating for health equity. They bring with them their expertise as health disparities researchers, as social epidemiologists, and through that lens can provide this audience with deep context for the disparate outcomes that we're seeing. But more importantly, in this pandemic where chronic disease has really proven to once again be a powerful determinant of morbidity and mortality, and in an era which we have been compelled to think about how we will teach and lead the next generation of healthcare providers, we have the tremendous fortune to really draw upon their collective experiences as general internists and of course as educators, so that they can help us think through the actions that we can take to really ensure an equitable future. And with that, the goals of this session are really to describe disparities in COVID-19 health outcomes, to evaluate social determinants of COVID-19 related health and healthcare disparities, and really drawing from lessons of the past to identify effective strategies for advancing health equity as general internists, as researchers, and as medical educators. And with that, I'll turn it back to Dr. Essien so he can introduce our esteemed panel.
Awesome. So again, I think we are all really fortunate to have this panel as the full standing room only, so to speak, webinar is showing. I think everyone is dying to hear these voices. They've been in newspaper articles, JAMA, annals, etc. And we're really thrilled to have them for this hour of their time. So first, Dr. Lisa Cooper is professor of medicine in the Division of General Internal Medicine at Johns Hopkins University. And she's the director of the Hopkins Center for Health Equity and also directs the Hopkins Urban Health Institute. We have Dr. Giselle Corby-Smith, who's professor in both the Departments of Social Medicine and Medicine at the University of North Carolina School of Medicine. She's the founder and director of the UNC Center for Health Equity Research. And lastly, but of course not least, we have Dr. Kirsten Bivens-Domingo, who's professor of medicine and the inaugural vice dean for population health and health equity at the UCSF School of Medicine. And she's also the chair for the UCSF Department of Epi and Biostatistics. So again, an amazing, incredible panel of leaders in this space who we're really looking forward to hear from this hour.
Thanks, Dr. Essien. So I'm just going to share a roadmap that we're going to use for this discussion. This is actually taken from a framework that was published in the American Journal of Public Health in 2006 that really describes the 3 phases of the disparities research agenda. And in this framework, it talks about 3 key steps that are sequential. And that is, the first is to really detect disparities, and then you move on to understanding disparities, and finally to reducing disparities. And so using this framework as a roadmap to really guide our discussion, we'll start out with the first step, which is detecting those disparities.
Yeah, so our first question goes out to Dr. Corby Smith. So we know that, for example, the Joint Commission back in 2006, which accredits 22,000 hospitals across the country, had already set standards for the collection of race, ethnicity, language data. This really seems to be the driver of the disparities discussion right now, the fact that there remains missing data related to race, ethnicity. And so I wonder if you can kind of share your insight as to what could be going on there.
Thanks so much, Utabe. So I think actually Lisa and Kirsten and I were part of the conversation to really push for, and 2006 feels like a long way away, but it wasn't actually in the span of our careers. It really pushed to have real data, race, ethnicity, and language data starting to be collected in a more consistent way. What I'll say that the way I think about the collection of these data is there's a difference between will and skill, right? So we have an issue of that 2006 sort of imperative that really tried to address the issue of will, that we need to be doing this. People need to see it as an important, we need to understand who is having which outcomes. So, because if you don't collect those data, disparities just disappear. And for a long time, probably, and still in some settings, the importance of collecting those data were questioned. So first, that's the will part. Then there's the skill, how it's collected, who's collecting the data, and in what settings, and the consistency of that collection of data as well. So the skill issue, I think, is still one that we're struggling with. There's heterogeneity in the way that those data are collected, sometimes by frontline staff, sometimes by self-report, sometimes there are places and ways that patients can actually provide their own identification. So part of it is, what does the person who's doing the interviewing or collecting the data either see and mark down? How much of it is it an actual query to the patient? And then how much of between those things are actually misclassification? Particularly in the states of North Carolina and the sort of southeastern region of our country, and maybe even towards the middle of our country, the southeast, the southwest, where we have a large Native American population, we see that there's a tremendous misclassification or just absent data at this point. We know that in some data that I was actually looking at this morning, that as much as 52% of the even now with COVID-19 and the push for reporting by race and ethnicity, that we're still just about half of those COVID positive cases actually have ascribed race or ethnicity to them. So we're still having a challenging time understanding the full scope of the issue and the scope of the problem when it comes to COVID-19.
Thank you, Dr. Courtney Smith. And I think we can all agree that it is really challenging to know disparities exist without the proper data. And another important step, though, that we think about in terms of just this framework of detection is really defining the vulnerable populations. I think certainly we get a lot of information from the age, race, and ethnicity data, but wonder if we miss anything when we stop our data stratification. And so this next question I wanted to ask Dr. Bibbins Domingo, who actually co-founded the Center for Vulnerable Populations in 2006. And I wanted to ask if you could tell us a little bit about how you define vulnerable populations and what other important populations or demographic groups or characteristics that need to be included as we move forward.
Thank you very much, and a real pleasure to talk with you all. So when we co-founded the UCSF Center for Vulnerable Populations, which I did with my colleague, Dean Schillinger, we were intentionally broad. We thought of vulnerable populations as those communities and populations who are at risk for poor health because of social inequalities, political inequalities, economic inequalities. The challenge with the name, of course, is that it can be read as a factor that's innate to an individual or a community. And in fact, these populations are oftentimes more resilient than vulnerable in the face of the types of inequities that they experience. The advantage, I think, of thinking about this in this context, however, and in the way that we try to set up in our center and the way it's now continues to be led by Dr. Marga Kuchel, is to provide an umbrella for many people who are thinking about vulnerabilities and who might be thinking across different types of demographic groups, might be thinking more specifically about specific needs. So some who belong to the center are thinking about racism and discrimination. Some are thinking about inequalities and discrimination that comes from sexual orientation, gender identity. Some are thinking about specific needs, housing, food insecurity, those types of things. And I think what has been really powerful has been to create that cross dialogue across experts who have a particular focus on a population or condition or need, and to think about what we can learn from each other. And if anything, COVID-19 has really, I think, brought that to light, and the need to have more cross-disciplinary conversations and conversation across expertise in particular communities. We have a very diverse area here in California and in the Bay Area, and understanding who is experiencing disproportionate impact in COVID-19 really requires understanding specific issues related to populations. In our area, it's oftentimes Latinx populations who are on the front lines as essential workers, but who have the additional impact of language and language barriers as we do our public health and clinical communication. That combined with then uninsurance and things like that. So these things come together in ways that sort of create these multiple vulnerabilities. And I think creating an environment where people can talk across those has really been very powerful for us.
Thank you so much for that explanation. I did want to touch briefly on one of the things that Dr. Courtney Smith brought up. I can advance my slides, which are the actual disparities themselves. And, early on, I think what our panel has alluded to is that many states really weren't collecting this data. This was data that was from May 6th, and it showed here the share of cases with unknown race, and the gray boxes show which states have absolutely no data collection. And I wanted to show a little bit of the progress, but again, show that we're still not where we should be. I think this is data that I pulled maybe 2 days ago, and this is data that Johns Hopkins is collecting, and it shows a few things. So this is the states who have actually released breakdowns of COVID-19 by race in the testing category. And so you can actually see that there's only 4 states at this point who have done that. In terms of confirmed cases, we have a lot more states that are actually releasing this data at this point. So 47 states have released COVID-19 data by race. And then we still have 43 states who have released the data in terms of the COVID-19 deaths in terms of race ethnicity. So we still have a ways to go. This is another image that was adapted from some people from the APM research lab. And it shows really the extent of the disparities based on the data that we have. And so a lot of things that we've seen in the media more recently has shown that there has been a profound disparity among African American populations. And so this graph is really just showing that compared to white populations, Black populations are 2.3 times more likely to have died from COVID-19 than white populations. And we see similarly high disparities in our indigenous populations as well as our Latinx populations. And so really that second part of detecting is really being able to define these disparities and understanding the magnitude of that. And I think I was going to turn now to Dr. Cooper because early on in the pandemic, and I actually think this is probably true of our entire panel, even before we had this data, you were expressing concern on news outlets as a leader that certain populations could be at risk. And so when this data did finally appear, Was there anything particularly surprising for you as someone who's been doing this work for a long time?
Yeah, I would have to say that sadly, no. You know, none of this was surprising at all. And we have all heard the old adage that when America catches a cold, Black America catches pneumonia. And so, you know, I think those of us who work in this field knew that once this disease hit the United States, that it would only be a matter of time before the people that were most vulnerable from a social standpoint were going to be hit the hardest. So it wasn't really surprising at all. And, you know, a lot of people have been calling this pandemic unprecedented, but, you know, as you well know, Michelle, from the piece that we co-authored in the Annals of Internal Medicine, this is not at all unprecedented. We've actually had epidemics, pandemics in the past where communities of color were particularly hard hit. And had very high case fatality rates, much higher than white Americans or the rest of the population. So it was only a matter of time, you know, that people who were unable to protect themselves by engaging in social distancing, who had to go out and work, who were frontline workers, who couldn't stock up on food for 2 weeks or more, you know, who didn't, in some cases, didn't even have clean water to wash their hands with, and who had less access to healthcare were definitely going to be hit hard. And so it wasn't surprising at all. And, you know, a lot of people said, well, you know, people of color are going to die at higher rates because they're already at higher risk for chronic conditions, and sort of, you know, said, oh, they're at higher risk for chronic conditions because of the individual behavior choices they make. And, you know, we've heard that narrative for such a long time. And I think now it seems like people are finally getting the point that, you know, people's decisions are based on the opportunities they have. And that's, you know, why we're seeing this disparate impact on our communities, and that it's not only about people's individual behaviors. So we're really seeing it. It happened with the influenza pandemic. It happened with the yellow fever outbreak. And what's different now is that we actually have the opportunity to capture more data and to actually do something about it, where, you know, back then we were limited in so many different ways. We still have some of the same limitations in our policies and in our structural, the legacy of structural racism that we have, as well as our social attitudes, but we have a whole body of evidence that has been created long before we even got started, and that we've been honored to contribute to, that informs us of strategies that we can use.
Thanks so much, Dr. Cooper, for adding that perspective. I think your piece with Dr. Gunale and your colleagues, as well as Dr. Bivens-Domingo's piece published back in April, This Time Must Be Different, and also in Annals. Annals is out here supporting our work, kind of showed that this is not new, this is not unprecedented. Your piece, beautifully titled, This Time Must Be Different, showed us that just 11 years ago, you don't even have to go back to 100 years ago. We saw a similar story related to COVID, or the H1N1 disparities. And so I don't know, Dr. Kirsten Bivens-Domingo, if you could touch a little bit more on what inspired that piece, and how would you compare those data to what we're seeing now in COVID-19?
Yeah, you know, I think the challenge, and what is easy to get sort of very discouraged about this, is just not only that we see this time and time again, but that we have seen it very recently with the H1N1 pandemic, and that people who've written about it have been able to point to very specific ways in which this happens. Just as Lisa mentioned, the groups we're talking about are groups that are more likely to be exposed because they are frontline workers oftentimes. If you look at the outbreaks, where we have outbreaks in this country right now, the outbreaks are almost exclusively in prisons and jails, in meatpacking and food processing plants, and in nursing homes. In the first two, African Americans, Latinx populations are disproportionately affected. And the shocking news is that even in the third, among nursing homes, that it is not all nursing homes. It is the nursing homes that have more Latinx and African American residents who actually have the highest rates of death, speaking to the intersectional vulnerability of what's the tragedy that's in our oldest age populations and the additional impact. So people have written about this back to H1N1 because we saw the same thing: disproportionate likely to be exposed, likelihood of susceptibility to severe disease once exposed, and then also differential healthcare access as the three big buckets that together put our communities at risk. And then I think what's even more discouraging is how much people have written about what we need to do to overcome this, how we need to have both broad strategies and then use our data and our partnerships to develop targeted strategies. And so the fact that we both have defined why this happens and also have thought about what types of solutions have been shown to work, I think both gives us a roadmap, but can also make us really discouraged at this time. What I tried to argue in that piece is that the fact that this is a massive epidemic, a global epidemic, the fact that this is one that is coming part and parcel with an economic pandemic as well, that will make all of our communities even more vulnerable, will make solutions even more challenging, but also the fact that we're living at a time when we are all interrelated in many ways. So, so the health of all of us, as my colleague Alicia Fernandez says, the health of all of us to help, the health of each of us depends on the health of all of us, is really important at this time. And I think the question is whether we can really learn from those things that have happened in the recent past, where people have clearly offered us ways forward in order to address what is this current crisis. And I think that is our challenge right now.
Yeah, I think that's a really important point, and it can be both discouraging but also motivating to know that we have a roadmap and the steps with which to attack this issue. I'll go back to you, Dr. Courtney Smith, as a professor in the Department of Social Medicine, someone who thinks about health equity and social determinants specifically as they relate to health. We've touched on essential workers, kind of certain prison populations and other at-risk groups beyond those with chronic diseases like hypertension, diabetes. I wonder if you could share a little bit more about what are some of the other structural factors that you're thinking about that both increase folks' risk of the medical comorbidities as well as just COVID-19 in general.
Thank you so much. So this pandemic has really revealed the fault lines between public health and our healthcare systems, right? Our needed response to sort of prevent the spread and as has been said, to flatten the curve, has really revealed the disassociation between our healthcare system and the acute response that was needed. And that left many people, and still leaves many people, actually in the wake of that dissociation for, in terms of their chronic medical conditions, as well as addressing their health-related social needs. For many patients, their ability to get food, housing, transportation, et cetera, are often tied to services that they also received within the healthcare system. So that alone, people that actually have access to care are actually now probably at more risk for lack of attention to their health-related social needs. We know in the setting of any community disaster and stress that the incidence of intimate partner violence and child abuse increases. This is a community, we know this, we've seen this certainly in North Carolina after and we're actually in the midst of our annual hurricane season. We've seen this time and again when we've had those community disasters. And so any testing and tracing response needs to make sure that they're addressing all of these needs, not only the need for testing in testing deserts that we're seeing by geographic as well as race, ethnicity, disparities across the state of North Carolina and likely across the country. We also know that for those that actually get tested, we need to make sure that we're addressing their chronic medical conditions as well as their health-related social needs. The other component of this is that I know in North Carolina, at least 10% of practices that are serving the most vulnerable populations have had to close. leading to even less access to care in some of our more remote counties. 80 of 100 North Carolina counties are considered rural, and those closures are primarily in rural communities that have already experienced closures of hospitals in rural communities. So further attenuating the connection to care that our patients need. Of those that have been able to remain open, they don't have PPE to be able to provide testing. And so again, we're seeing that this sort of disinvestment within communities that are the most vulnerable socioeconomically has led to sort of a continued sort of erosion of the quote unquote safety net that now has big holes for communities that are already marginalized by the healthcare system. And I just want to go back to, I think Michelle was pointing out the data around disparities in health. Crystal Sine, who's part of our SGIM's Health Equity Commission, recently gave a presentation, and she noted that when you look at the disparities by race and ethnicity, if they had died at the same rate as white Americans, at least 14,000 Black Americans would still be alive, at least 1,200 Latinx would still be alive, and 200 Indigenous Americans would still be alive. And we're still having really hard trouble getting data on Indigenous Americans, Native Americans. So those data may actually be even worse. This is incredibly troubling and really worrisome. And I think that some of the work that Kristen and Lisa have pointed to in terms of how do we, I mean, we're in a pretty deep hole right now, and we have not only to contend with the acute insult of COVID-19, but the delayed care when it comes to the chronic medical conditions that so many people have, the social determinants or the structural drivers, I would say is my preferred term, the structural drivers of health. And then the last point I want to raise is this issue of the sort of rampant COVID infections in incarcerated populations. The reality is this actually is one of those canaries in the coal mine, because so often, I would say in every case, frankly, COVID-19 entered into incarcerated populations from the workers that brought it in there. So often workers that, because those incarcerated populations are in congregate settings, they would not have been exposed had it not been brought into jails and prisons. And that shows that tie to the community and potentially the risk as people are increasingly called, and I'm one of them, calling for decarceration of those populations to try to reduce and mitigate the risk of COVID-19 infection there. Now we need to think about ways to ensure that those individuals are brought into care. People like Emily Wang have the transitions clinic to be able to be sure that those patients not only are cared for in terms of their chronic medical conditions, but also are tested on release and then later on. So I think the social determinants of health, I mean, this is a pandemic that really reveals how important it is to be thinking about those social drivers in not only the acute phase of this pandemic, but also the long-term impact.
Yeah, I just want to underscore a little bit what Giselle said so beautifully, but this issue in our incarcerated populations, you know, I think the data out of New York Rikers jail system is that in the jail system, first of all, jails nationally, there are 200,000 individuals that go in and out of jails every single week. So anyone who doesn't think that this is a community issue, this is totally a community issue.
Exactly, yes.
Totally a community issue. Secondly, in the Rikers jails, most of the infections were actually in the workers in those jails. So another way in which this is really a community issue. And then thirdly, many of the prisons that we're talking about with outbreaks are actually prisons that sit in rural communities and communities that really are least able to think about the surge capacity that's required when you have a massive outbreak in terms of hospitalizing COVID-19 patients. And so I think the issues of incarceration and the inequities in incarceration are playing themselves out in all aspects of the pandemic in the face of incarceration that we're seeing right now.
Thank you. Thank you both for sharing that. I think that we have, throughout this discussion, sometimes it can be a little bit discouraging just to think about how profound these disparities are. And again, thinking about how this is not necessarily a new phenomenon. But I do know that what we've touched on, and what I think the hope of this session was too, is to think about how we move forward. And so I want to turn now to kind of the last part of our roadmap, which is really reducing these disparities. And I know in 2019, Dr. Cooper, you published along with Dr. David Williams on the topic of using what we already know to reduce inequities in health. And so I encourage our listeners to definitely read that, and just a plug that we are including a reading list just in case anyone wants to read any of the articles that are being mentioned. But I think the premise we can gather even from the title is that something that this panel has obviously done a lot of work and can attest to is that we do have the tools and strategies, and there are things that we know work. And so as we think about this unique moment and history with COVID-19, and more specifically as our role, in our roles as researchers and medical educators and clinicians, I think we'd like to ask each of our panelists about moving forward. And so I'll actually start with Dr. Courtney Smith. In terms of research, we know that in the months and years ahead, research will continue to really ramp up for COVID-19. And you've spent a good part of your career investigating how to really engage communities of color, particularly African-American communities, in clinical trials. And we know that this will be critical. Can you talk a little bit about that and maybe other best practices for research design as we move forward?
Thank you so much for that question. The issues are, as we think about the research that's still needed to be done to understand the best ways to best testing strategies and interventions, there are certainly several NIH funding announcements that are open now to continue to understand the best ways to reach populations and using community engaged research to do that. I think part of it is having, as I talk to my team, having a good ground game, making sure that you're connected with trusted organizations that you, as a friend, Bettina Beach had mentioned many years ago on a panel that we were both on. Make sure you're showing up when you don't want something. Establish those community relationships, not only and not solely for research. You need to be able to be there when the research isn't happening. You preferably even have those relationships ahead of time. All of our organizations that have clinical and translational science awards have a community engagement core. And that core initially, however many funding cycles ago, was quote unquote was to increase public health, public trust in research. But the reality is that these relationships need to be long-term. And it's about demonstrating the trustworthiness of the organizations that are doing the research. People mistrust health research for many, many good reasons, historical as well as present day. Not only in the setting of misinformation that we have now, but even in the setting of particularly in the setting of unethical behavior in the past. Many, in some of my early work, I remember a quote from one of the participants, a Black American male that was being cared for at Grady Hospital, where I was doing work there. And he said, you know, if I do all of this for society, given the way Black folk are treated, how's it going to help me? So they take, and rightfully so, our patients take their experiences in the healthcare system and extrapolate to what it's going to mean for research participation as well. So the demonstrating trustworthiness is not just for the research enterprise, but what are we doing today to address health inequalities, broadly speaking, and in particular around COVID-19, to demonstrate the trustworthiness of us as participants in the healthcare system and the research enterprise. And so that is, I think, going to be a critical factor in any research that's rolled out from here on. How are we identifying partners on the ground that can help and that can, through our collaboration, ensure that we are doing the things the right way and addressing community needs in the ways that and doing research in the ways communities want that research being done. And then secondly, how are we as healthcare system providers and researchers, academic researchers, and educators demonstrating our trustworthiness so that people can participate in research? I'm constantly trying to flip the script. It's not about people distrusting. We just haven't demonstrated that we're trustworthy.
That's a really important point. Thanks so much, Giselle. And I think an important point for the medical education sphere as well, which is another broad bucket that we as SGIM leaders play an important role in. So I'm going to turn to Dr. Kirsten Domingo as a RISE scholar, so one of your mentees. I'd love to hear how shout out to RISE, and everyone should apply next year. I'd love to hear how you think about education playing an important role in addressing disparities, both in this moment and just more broadly.
Yeah, I mean, I think that as the people on this panel show, and I think about in my institution that really representation matters, and that the priorities of an institution really play out by who is in the institution and the commitments that they bring with them from the beginning. And I think it does speak to both both fundamentally our need to make sure that the populations we hope to serve are represented in the people that we are training as health professionals to serve them, but also that for people within our academic settings, that we're giving the right types of tools and actually developing the right types of networks so that we are not just a part of these institutions, but really in positions where we can set the agendas and make sure that the type of work, as Giselle is talking about, actually rises to the top. One of the things that I know I feel really fortunate to have been a part of is, for example, the Robert Wood Johnson Harold Amos career development program, not just because it was important for me as I started out, but it helped me to become part of an entire network where I met Lisa and Giselle, in addition to SGIM, which is wonderful at creating these networks. I think these networks are important because we are oftentimes can be isolated in our own institutions, can have limited voice within our own institutions. But across a network, I think we actually are seeing some of the change that we're hoping to see. One of the things I would just want to point out in the way Giselle talked about research in communities, I do want to say that as physicians, we have a responsibility to make sure this starts first within our healthcare institutions. And one of the things that I have been really proud of, and really a lot of people from SGIM really leading the way, is making sure that what Giselle started out with talking about with the race, ethnicity, and language, that those types of data collection is happening within our institutions, and we're using them in ways to really hold our own institutions accountable for disparate outcomes we might be seeing. And groundwork that was laid by several general internists at UCSF, as well as many others, really, I think, has led us to start looking more closely at our data, and really, I think, held us in somewhat good stead when this pandemic hit, that we could start to see, were we testing at the right rates? Where did we have to look a little bit more in order to put resources? And I think all of us do different types of research. Probably we're all physicians, that's why we're here at SGIM, and I think it's important to say that even within our own setting, that we start first and make sure that these principles that we're talking about play themselves out essentially in our own backyard where we have the most control.
Thank you so much for that. I think that just leads us perfectly into our final bucket as clinicians. And I now want to turn to Dr. Cooper, who has really spent her career looking at patient-provider relationships and really issues around trust within the clinical relationship, the clinical encounter. And I just wanted to talk a little bit about your work in this area and how it'll be important as we move forward.
Well, so I just want to say, first of all, just what an honor it is to be on a panel with my two esteemed colleagues, and just to have all of my SGIM family here, because as everyone's mentioned before, so many of us have been in the trenches working on these issues for decades, and I think we're going to be needed now more than ever to help address this issue. But so what's been alluded to earlier is that the importance of us building trust with our communities, whether it be at the organizational level or at the individual level. But as many of you know, people form their opinions and decide about their actions related to healthcare or to research based on their relationships with, often it's with their primary care provider, and that's why we play such an important role. And so, from a lot of the work that, I've done and a lot of colleagues in SGIM and around the country, we really demonstrated that, in fact, the patient-physician relationship was a pivotal piece in at least the healthcare disparities equation. And now we know that it's even an important piece in addressing some of the broader social determinants, because oftentimes it's through that relationship that those social needs get identified, and physicians play an important role in advocating for their patients and in building relationships with important community-based organizations. So, we talked a lot about trust. In order to be trustworthy, we have to demonstrate that we are benevolent towards people, that we actually have good intentions towards them, that we have integrity, we do what we say we're going to do, people can count on us, and that we have competence, that we are actually qualified to deal with the issues that we're dealing with, and that we are taking a holistic view of it. So I think if we bring all of that into our, not only into our relationships with our patients, but also into the way our organizations operate and interact with our communities, we're in a very strong position to advocate for the change that we need. And we bring that into our relationships with all of our other colleagues from the multiple sectors that we need to work with to solve this issue, and from the multiple disciplines that we need to come up with the most effective interventions and to actually implement them in a way that they will be sustained. And so, I mean, we need everyone to solve this problem. We need all the intellect, all the passion, and all the skills in articulating the issues. So I'm just honored to be a part of this movement. I know it is a movement, and I think we're at a really critical point where we can play, as general internists, play a very important role. People do look to us as trusted agents, and we need to step up to the plate and be worthy of that trust.
So thanks so much, Dr. Cooper, for that response. I think that comment particularly kind of brings us to the final set of questions that we had prepared before we go on to a few of the questions that folks have asked, and we'll continue to encourage folks to use the Q&A panel there. I think we would be remiss if we didn't talk about the current climate or the current moment, whatever the phrase folks are using nationally that we're experiencing right now. We know Dr. Kimberly Manning's a fellow SGIMer, recently wrote in the Journal of Hospital Medicine at the intersections of COVID-19, complete with its inordinate impact on minorities, the acuity of grief felt by the most recent events of racism have coalesced to form what feels like a pivotal point in the arc of justice. And so we've seen, whether on social media, letters, emails, op-ed pieces by our colleagues, the text messages I'm sure we've all seen, just how challenging this moment has been. I acknowledge that 5 of us who are on this panel now are people of color, Black Americans more specifically. And so just, I would allow all of you the opportunity to kind of share how this moment has been for you, and what should leaders at institutions in particular be thinking about how to address the legacy of racism and health equity. And maybe I'll start with Dr. Courtney Smith there.
Yeah, does feel like a watershed moment for us and an opportunity. I've been telling colleagues that, the window's open and it's time for us to sort of break it down, to start really thinking about the structural change. I've been talking with the leadership at my organization. I laid out a framework that focuses, one, on racial healing, and drew on the sort of model of the Kellogg Foundation and their ideas of how to sort of move forward in terms of racial healing. And then talking about structural change. And that to me is the place where these two places, the way we hold them as anchor institutions and academic medical centers and institutions of higher education, those are opportunities right now for us to demonstrate our trustworthiness. How are we going to respond in the face of these calls for structural change? The notes of solidarity are nice. That's great. And in some ways, it's actually become pro forma for lots of organizations to put these out. What I'm interested now, and have been for a while, is about the structural change that's needed at our home institutions. How are we addressing this legacy that's built on a hierarchy of human value, where some are valued more than others and given more advantage than others, and so what are we going to do about it? How are we going to continue to work in and through our organizations to affect change, not only within this, and to address the structural racism that's happening within our organizations that each of us have experienced probably more times than we're willing to talk about. The hashtag Black in the Ivory is just a really poignant reminder of how incredibly pervasive racism is in our academic health and our academic centers and our institutions of higher education. I actually, over the weekend, just had to turn it off because it was just so painful to read. And to know, to know that the kinship that I feel with so many others is in part based on that ubiquitous experience. But then also, in addition to what's happening within our institutions, how are we addressing the fact that we actually, in our academic medical centers, in our institutions of higher education, have the social and economic influence to be able to affect structural change in the communities that surround us? It's just, again, this is about will versus skill. This is about having the will to make those changes, to make the changes for inclusive supply chains that preference minority or women-owned businesses, or businesses that employ large numbers of minority employees. That thinking about economic development in the community surrounding, and I'm sure Lisa in her newest leadership role is probably thinking about those kinds of structural changes that can happen in Baltimore. How are we walking the talk? If we say, and we have seen these notes of solidarity, so what's the next step? And I would implore everyone on this call and anyone that's listening to this to push for those kinds of structural changes. And I can later on leave some resources as this goes out to think about what does it mean to be an anchor institution? How can you think about the Institute for Healthcare Improvements, equity, looking at an equity lens, using an equity lens to think about health disparities? I'm going to stop there. I could keep going for the remainder of the time. I feel like we're poised at this moment that real change can happen if we all push for it.
I see Dr. Cooper unmuted, and I know that Dr. Courtney Smith mentioned her. Maybe I'll let you share briefly before we go into the questions.
Oh, sure. No, I think I just forgot to remute myself, but I can always say more. I mean, I couldn't agree more. I mean, I think one of the ways I like to think about this is that, this is a multi-layered problem, so we have structural racism, we have interpersonal racism, we have cultural racism, right? And so we need to try to address them on all those different levels. And the way that I think about it is, because a lot of my work has been focused on strengthening relationships, is using a relationship-centered framework. So how we start with ourselves, look within ourselves, and who are we, and what are some of our own biases and contributors to the problem. And we begin to really look at ourselves, honestly and begin to work on ourselves, right? Then we look at all of our other relationships, our relationships with our colleagues and with the leaders of our institutions. You know, are we being authentic? Are we speaking truth to power with them? Are we holding them accountable? And then are we relating in that way to our patients, of course, and our research subjects, and then to our community partners. So looking at all of those relationships and really addressing the ways in which implicit bias and racism could have harmed those relationships and what we can do to rectify those. So I think those are some of the ways that we can do the work that we've been talking about doing. And, you know, I had only unmuted myself by mistake, but since you gave me the microphone, I took it.
Well, thank you so much for your comments. I think we all feel like we could be here for several more hours discussing this, and it's certainly not enough time to really get into the complexities that are really needed to move forward. But I did want to turn to some of the questions from the panel. I know we have just a few more minutes left here, and so I will read these questions, and I think these are for all the panelists, so anybody can feel free to answer. So one of the panelists has asked, is anyone researching or writing about potential discriminations in certain states' crisis standards of care, the triage algorithms? Please let us know. So I don't know if any of our panelists are aware if anyone's doing research or writing about, I guess, discrimination in crisis standards of care.
Yeah, I think I don't know exactly what the question is getting at, but I think people are writing about, well, there have been many cases, and probably not documented in the way that we need to, about the delays in testing, in the triaging of levels of care based on underlying comorbid conditions, based the access to ventilators and types of treatments and things like that, which all rely on a framework for decision making that says, who is this person and does this person merit this set of things that are going to happen next, right? And I think people are writing about that. I think those of us who come at this with a long history of health disparities and a health equity framework, I think have a responsibility to engage in that, because I think there are ways in which we as a medical, you know, the medical community has a history of engaging in research about how do we do triage, but having an equity lens is not always applied to that, and understanding that within both a local context and a national context, I think, is critical. So I think there's work, but that doesn't mean the person who is asking the question shouldn't also engage in that work.
Thank you. And it seems like there are a lot of participants who are interested in some of the resources that Dr. Courtney Smith mentioned. And so I think at the end of this, perhaps we can figure out a way to collect some of those things and make sure to send them out specifically. And the other question, I think, for Dr. Courtney Smith was, one of the panelists said that they were struck but not surprised by your remarks about the 10% of practices that serve underserved populations have closed. And they said that legislation seems to have missed this. So I think the question is there any policy or legislation that we should look out for to help these providers that are serving these populations but may not be plugged into a larger system of care?
The 10% that I quote is in North Carolina. I don't know how far-reaching that is. I wouldn't be surprised if it was a similar percentages in other states, particularly in states that are serving rural communities, because the challenge is that for many of these practices and also many of the hospitals, some of their major revenue generating sort of procedures had to close at the same time, where they had to pivot to address acute infection, had to stop a lot of in-person visits. We had a little bit of a lag in terms of getting telehealth up, although within 2 weeks, many practices were able to do something that took many years to even recognized as a way to care for patients. So in terms of legislation, I'm not 100% sure of what legislation there is currently. I know that there have been several things over the years that have been trying, over the last several months, that have been trying to address and mitigate the impact on providers in particular and small businesses. Most private practices would be considered small businesses and would be eligible for sort of the Payroll Protection Act and some of the other other legislation that come down the road. But there needs to be more. I mean, the hospitals and healthcare systems in our most underserved communities are going to be hardest hit. Number one, because of the burden of caring for acute COVID-19 infections. The per capita, particularly in our rural counties in North Carolina, far exceeds that in some of our more urban centers. So number one, they're already dealing with far more with less resources, even to start out with. The number of healthcare settings are getting smaller and are overstretched, and will be even more overstretched as chronic medical conditions are left untreated and or actually emerge in the wake of the sort of chronic individual as chronic community stress that we see our communities under now.
Thank you for that. And there are a lot of questions in here, but I think we'll have time for one more. Since we had a robust discussion about the prison population, it looks like one of our participants is asking about the relationship between disparities in healthcare and plans to reform or defund police systems in favor of funding social services, and maybe if anybody could comment on that as a strategy.
I'll start out, and then of course I welcome my colleagues to join in. I think that one way of thinking about this is really if we continue to frame the violence that's been perpetrated against our communities as a public health issue and less as a criminal issue, I think that's when we'll be able to get more buy-in and support for addressing sort of the social inequities that contribute to these problems, and for coming up with solutions that actually are more focused on addressing those issues and seeing this as more of a public health safety issue than one that requires policing. And so I think this is a real important opportunity for health professionals and public health professionals to come together and really to frame this issue as a public health issue in order to make movement, make progress in that arena.
Yeah, I couldn't agree more. I think Lisa said it really well. I do think the opportunity of this moment, COVID-19, the COVID-19 disparities, and then the attention to police violence and police violence in particular against Black communities is because it allows us, if we seize this opportunity, to see these as under the same structural racism and systemic inequality as undergirds both of them, that they require us to think about systemic solutions. And they require us as health practitioners to think about this from a public health framework. These are not isolated one-off incidents. They come together in ways that are so critical for the communities that we care about, and they're public health issues. And if we can frame them that way, it allows us to basically lead with what we know best to try to think about how to develop the appropriate solution.
Yeah, I would just say, that for a long time, the murder of Black men and women and Black and brown men and women by police was sort of framed as a sort of one bad apple, another bad apple. And this is really that the entire tree is diseased. This is about structural racism and also the militarization of the people that are supposed to be protecting and serving us, and the defunding of many social services to be able to fund those, to fund the police system, the police departments, and their unions. And so we see a disparity in a different way, right? We see that the key social services that have been defunded are now shifted to police officers to have to address, and they have no skill or training to be able to do that. And so everything that they see and the underlying racism that undergirds the system ends up pushing us further and further into a place of confrontation. This is really the racism, this is sort of so emblematic of racism as a public health issue. When you have men and women, Black and brown men and women just dying at a disproportionate rate, 7 times the rate of white adults, and children, it's just abhorrent, and we need to address it. And I guess that little beep means that we're out of time. I heard a beep. I don't know, but I'll stop talking there.
We are unfortunately out of time. And again, I think we all wish we could continue this discussion for many more hours. There's so many things that we really can't get to within an hour, but hopefully we'll be able to send out resources so people can continue educating themselves and also asking these important questions. I also did want to make sure that people are aware that SGIM has put out position statements on ensuring equity amid the COVID-19 pandemic, as well as a position statement on social determinants of health, so that people are aware of that. And there is a special call, a theme issue on systemic racism in medicine for the Society of General Internal Medicine Forum. So just so people are aware of those resources. And I think that we have touched on a lot of challenges and also got to think about some potential solutions. I did want to just end with this quote to kind of take us off on a positive path. This was a quote from Dr. Hardiman, Medina, and Boyd in a recent New England Journal of Medicine article called Stolen Breaths. And they mentioned that the response to the pandemic has made at least one thing clear, that systemic change can in fact happen overnight. And I think that, you know, as we move forward and the things that we are talking about are going to require a really heavy lift, just knowing what's been able to occur in the setting of this pandemic and how the systems have been able to really be changed in a rapid way is hopeful. So I think that we all have a duty to kind of advance these principles as physicians and as educators and those in positions of leadership, and so that these changes can move forward. So I will end there and obviously thank our incredible panel for their insight. And like I said, I wish we could do this. We should do this every Monday, but we know you all are incredibly busy. So thank you so much for your time. I think that's it.
Yeah, really. Thank you guys.
Thank you.
Stay safe, everyone.
Thank you.